Thank you, chairpersons, and thank you, Dr. Banshi, and the entire organizing committee for having had invited me. So I've been asked to talk against the use of BMI in DCA's practice. Okay, just to give you a small background. So what is BMI? If you see this BMI, okay, so this was first introduced in the 19th century. And we know that BMI is nothing but weight upon height in meter square, right? But what happened in the 20th century? Overweight and obesity were increasing. And then somewhere in the 90s, there were a lot of drugs that were introduced for obesity. One of them, is pancreatic lipase inhibitors. Then you had the GLP-1 analogs. So basically, there was an era where medicalization of BMI had started. So that was somewhere during the end of the 20th century. And that is when this categorization or grading of BMI was done and the different categories for obesity was proposed. And this was then given in 1997 by the World Health Organization and then subsequently even approved by the US government. Now, if you take a look at the prevalence of obesity as per the body mass index, so you can clearly see here up until 1980s, it's almost like the graphs are flat in nature, irrespective of the age group. You take younger individuals, you take elderly people. So it is impossible that irrespective of the age, the sex, the ethnic groups, and all of them have very diversified behavior, so it is very unlikely that someone who has a very good lifestyle compared to someone who doesn't, still there is a spike that is seen in the prevalence of obesity as per this BMI grading. And it is also unlikely that there has been some major changes in the genetic makeup which has contributed to this upsurge in the prevalence of obesity as per the BMI. So it is clear that neither lifestyle or genetic factors have contributed. And like I've already mentioned, it is the medicalization of BMI which has happened in the late part of the 20th century, which has contributed. And of course, rapid urbanization, the global economy in India had opened up, and food, supply had changed. So all that has contributed. But mainly the pharma industry driven categorization of BMI has led to this upsurge. Now, if you see the BMI, there are some critical flaws. So it appears to be a very oversimplified measure. It ignores the fat mass, the muscle mass. It does not categorize between subcutaneous and the visceral fat. And also it lacks individualization. As I've already mentioned, it does not account for age, the sex, the ethnic groups, also the genetics, and it can be a poor progress tracker. So it does not really reflect any improvement on the metabolic health. You don't come to know anything on your blood sugar improvement, blood pressure, cholesterol, or any of the changes related to lifestyle. There are better alternatives that are available. So the waist circumference, the waist to hip ratio, you have the DEXA scans, which are more quantifiable. So that will give you an exact measurement of the visceral fat. You can differentiate between visceral and subcutaneous fat. And sometimes, when you label someone on BMI, you might be stigmatizing that patient. Because if you have someone who's a little more muscular in nature, you might grade them as having a higher BMI. The other way down, someone who has a lower BMI might have more visceral fat, the thin fat Indian, and you might not categorize. So someone who's having a higher BMI, you might label them as obese. And for the Asians, there is a much lower cutoff for BMI. So stigmatization and misdiagnosis is possible. So this oversimplified measure, like I said, does not give you an exact measure of the visceral fat. So an abnormal BMI will only tell you as per the height whether the weight is abnormal or no. So like I said, if you have a more muscular guy, an athlete, more muscle mass, his BMI might appear on the higher side. And in these individuals, it's seen that if you see the 95% confidence interval for body fat, it can be anywhere from 10 to 32%. So there is a wide confidence interval, which means that if you label them as overweight, sometimes you might underestimate the fat or you might even overestimate the fat percentage. So what are the limitations of using the BMI? So like I said, it will give you an estimation of the body weight. It might help you in tracking the weight in the population, but it doesn't help in estimating the body fat, especially categorizing the visceral fat. use in genetic studies maybe, but the pathophysiology of obesity is not defined as per BMI, and phenotyping of obesity cannot be done. Now, this is a study, very interesting study. Now, you have four groups here. So, if you see on the left-hand corner, the top and the bottom, you have the male and the female who have a BMI of 22. So, you can label them as having a normal BMI. And if you see their waist to hip ratio, it's anywhere around 1. And the chance of death in them is much higher because their waist to hip ratio is higher despite having a normal BMI. And on the other hand, you have someone who has a BMI around 33, so more heftier, both male and female, but they have smaller abdominal sizes. The waist to hip ratio is on the smaller size. It's almost around zero point 0.8 to zero point 0.9. And here it was seen that the chance of dying is much lesser despite having a higher BMI, but their waist to hip ratio was on the lower side. There is another study which has looked at BMI versus the metabolic health. So on one hand, they've looked at the anthropometric parameters, and then they've looked at the adiposity indicators like waist circumference, the waist to hip ratio, and they wanted to see what is the risk of developing type 2 diabetes in this individual. So this was a systematic review and a dose response meta-analysis of cohort studies. And here it was seen that all the individuals who had a normal BMI but had a higher central fat had the higher likelihood for having metabolic dysfunction and the risk of developing type 2 diabetes. So there is definitely an underscoring of this central fat distribution in someone who has a lower BMI. So you can see here the results here. So I have labeled it here: waist circumference, waist to hip ratio, the percentage of body fat, and also the body adiposity index. So if you see the relative risk here, it is anywhere above 1.6, almost reaching 2 for the risk of developing type 2 diabetes, whereas for BMI and all the other things, the risk was much lower. There are other two population-based studies. One is on the left-hand side, the US data, the other one from Spain. And both of them again have shown the association between BMI and the association with LDL. So on one hand, waist circumference with LDL and BMI with LDL. So here again, you can see people at a lower BMI. You can see that the LDL levels are on the higher side. In fact, people with a higher BMI, the LDLs tend to drop. This is not only in the US population, but also in the Spanish population. Lower BMI, LDLs are on an upsurge, and as the BMI increases, the LDL comes down. So this is the study I was referring to. So the NAN study from the US, population-based registry study, and the Enrica study. This is Spanish data. Both of them very identical. They've done a further subgroup analysis. Now they've categorized them as per the metabolic syndrome criteria. So if they have 0 to 4 metabolic syndrome criteria, and also they've categorized them based on age. Here again, you can clearly see if you have more of metabolic syndrome risk factors, the LDL association, the LDL increase is much higher. And then it tends to come down once the BMI is on the higher side. Only in people who have a lower BMI, they tend to have a higher association with LDL despite having multiple risk factors. Similarly, people, irrespective of their age, whether 40 to 65 or even 65 and above, here again, lower BMI 20 to 25, the LDL levels are on the elevated side. And as the BMI increases, there is a plateauing of the association of BMI with the LDL. So here again, they've clearly indicated you might be on the leaner side, you might be having a low normal BMI, but still the risk of having metabolic parameters derailed are much higher in individuals with a lower BMI. One more study, this is about the new onset of type 2 diabetes, what are the BMIs in these individuals and the risk of mortality. So here again, there is, you see, even someone who has a lower BMI, 18 to 22 versus someone who has 33, the the risk ratio for developing mortality is exactly the same. Whether they're young, whether they have a lower BMI, whether they have a higher BMI, the risk of mortality is the same. So I would just like to say that you have better alternatives to BMI. The waist to hip ratio, the waist to height ratio, these could be a better predictor for metabolic health as compared to BMI. And these are measures if you measure the waist to hip ratio, it'll give you a better indication of the central adiposity and valuable insights about the metabolic health rather than choosing for BMI. Apart from waist to hip ratio, waist circumference, you can also look at the DEXA scan, the dual energy X-ray absorptiometry, and also at the bioelectrical impedance analysis. So these are again further deep diving into the visceral fat. It'll give you a better distribution of the visceral fat as compared to a BMI. So definitely we have better options to deep dive into an individual's metabolic health rather than just looking at BMI. So metabolic markers, body fat percentage, waist to hip ratio, waist circumference, many studies have shown that they are much better predictors for cardiovascular disease, diabetes risk, rather than using the BMI. And there is, this categorization. If you see in the Chinese population, someone as overweight has been categorized between 24 to 28. If you see in the Indian population, it is 23 to 25 overweight. And studies have shown that people who are obese, as well as people who are in the overweight category, or even in the normal BMI, might have the same amount of visceral fat. So this categorization has really not helped. So we need more comprehensive tools. BMI looks more into the macronutrients, not really into micronutrients. Based only on BMI, if you categorize someone as obese, then it can be discriminatory. It can lead to inaccurate diagnosis. In fact, some data has even shown that employers, they increase the employees' health insurance costs based on BMI threshold. So it might be even expensive for the employee if you go by BMI. So waist circumference, waist to hip ratio, DEXA scan, and other tools are available, which we'll have to go for. So I'd like to just summarize my last point. BMI does not differentiate between muscle as well as fat mass. A thin guy might have more visceral fat. A guy with a higher BMI might have more muscle mass, but still we are trying to categorize them as normal BMI or obese. We ignore the categorization of visceral versus subcutaneous fat, and BMI doesn't take into category age, sex, ethnicity. It overlooks the metabolic health, as I've said, in normal weight individuals. And I've shown you two, three studies where people with higher BMI had lower risk for mortality, and lower BMI had a higher risk for mortality. And same is the risk for developing type 2 diabetes. So the thin fat Indian or the Asian Indian phenotype ideally should not be looked through a BMI's lens. We'll have to use the waist circumference and other parameters. Thank you for a patient hearing.